Good evening, everyone. In today's VR class, I, Dr. Ramya R Nadig, would like to present a clinical case discussion under the moderation of Dr. Lingam Gopal sir. So let's decode the diagnosis. The overview of this session is divided in these parts. That is, first will be a clinical case review with discussion of possible differentials, then an ERG discussion, genetic discussion, and at last we'll have a clinical perspective and conclusion. So the story begins like this. A 5-year-old male child consulted elsewhere on 25th of November 2004 with acute progressive painless diminution of vision in both eyes, left more than right for 3 days, preceded by a fever history 10 days prior to presentation. On examination, the visual acuity in both eyes was 1 by 60, and he was diagnosed with bilateral optic neuritis with vasculitis and treated with IV methylprednisolone and oral steroids. 4 days later, that is on 29th of November, his recorded visual acuity showed improvement in the right eye, that is from 1 by 60 to 6 by 60. However, the left eye remained the same. The documented fundus findings at that time was both eye retinal edema, sheathing of vessels, but no disc edema. He was referred to us and he presented to us on 1st of December 2004 for a second opinion. Both eyes showed no RAPD, anterior segment was within normal limits, AC was quiet, vitreous cells were present, both eyes showed disc to be having disc pallor, sclerosed vessels, and he was diagnosed with a provisional diagnosis of viral neuroretinitis. He was advised for an examination under anesthesia and AC tap. So this is the fundus posterior pole picture in 2004 of the boy when he was 5 years of age. This picture shows the glistening reflex that you can see in the normal pediatric age group. Both eyes shows disc pallor left more than the right. We can also see some sheathing of the vessels in both eyes, some sclerosing of the vessels in both eyes, and also some macular pigmentation, yellowish deposits in the macula. So the EUA was done and the same findings were documented. He was started on systemic acyclovir and steroids. The AC tap showed, however, negative for herpes simplex, cytomegalovirus, and varicella zoster. The CSF also showed negative for the said viruses and also for Mycobacterium tuberculosis. The serum anti-rubella virus IgG, however, showed low positivity, but the mother informs to have got the child vaccinated for an MMR vaccine. So coming to the timeline of events following our case, the next day we could see that the visual acuity in the right eye was counting fingers 1 meter and hand movements close to face. He was on acyclovir and steroids. He was serially followed up and we can see that there is some improvement in the right eye, whereas the left eye remained the same. After 1 month, he was stopped on oral steroids. However, the acyclovir was continued. After 2 months, the acyclovir was tapered from 400 mg to 200 mg, which continued for next 3 months. We can also see that there is consecutively there is improvement in the right eye, but left eye remained the same. In 2005, after 6 months of presentation, all the treatment was stopped. And at that time, there was a query whether both eye rubella retinopathy is present. He was again serially followed up every year. And at that time, the provisional diagnosis was of a healed retinitis in both eyes. The next fundus picture that we have in our records is at 2008 when the child was 9 years of age as compared to the 2004 posterior pole picture shown above. So in this fundus montage picture, we can see that the right eye disc appears to be hyperemic. There is RPE mottling along the vessels. There is some hyperpigmentation along the vessels as well. And few pigment clumps have just started in the superior temporal quadrant. In the left eye, the disc appears to have temporal pallor. Again, we can see RPE mottling, which is along the vessels and also in the mid-periphery, and some few pigment clumps that have started in the superior quadrant. Also, the macular area does not look healthy. It shows minimal scarring kind of a picture. Coming to again following up the case from 2009, the right eye vision almost improved to 6/6. However, the provisional diagnosis still remained as epitheliitis, healed RP epitheliitis. In 2012, he presented with mild pain in the left eye for which he was treated symptomatically. This is the fundus picture in 2012 when the child was 13 years of age as compared to that of 2008. Here we can see the appearance of the pigment clumps, which was first noted at 13 years. And we can see that it is distributed along the veins in the right eye and also probably in the left eye. We can see more pigment clumps in the left eye actually. Coming to the next visit, which was in 2013 and then in 2015, where there was a query whether it could be salt and pepper retinopathy. And again, a fundus picture was taken. At this time, he was 16 years of age. This is compared to the previous fundus photo at 2012. Here, what we can see is the addition of these well-defined hyperpigmented lesions subretinally, which have started to appear along the arcades in both the eyes. Also, the macula shows atrophy in the left eye. This is the first autofluorescence image that we have of this patient, and it also shows hypoautofluorescence corresponding to these subretinal well-defined lesions along the arcades in both eyes and also along the pigment clumps. So coming to 2017, where it was suspicious to be an RP, that is pigmentary retinopathy along the veins, along the vessels, and we also ordered for an ERG, OCT, and visual fields for this patient. However, something to keep in mind right now is there was no history of febrile illness in the mother during pregnancy, no history of consanguinity in parents, no history of vision worsening at night. Sibling had no complaints and no history similar complaints in the family members. So this is the fundus posterior pole picture of 2017. We could not get the full montage in 2017. However, we can see that there is development of mild cataractus changes now in the left eye, which obscures the macular details. The fundus posterior pole almost remains the same, but these nummular well-defined hyperpigmented lesions seem to have increased. This is the next autofluorescence image in 2017 as compared to 2015. Again, it shows hypoautofluorescence areas in the areas corresponding to those lesions on the fundus image. Coming to the ERG findings, we can see that there is a reduced response both in photopic and scotopic ERGs, almost extinguished responses. And also in the OCT, we can see that in the right eye, there is almost normal foveal contour with the preservation of the RP subfoveally. However, there is loss of outer retinal layers. In the left eye, again, there is foveal thinning, widening, and loss of outer retinal layers. Coming to the fields, that is 30-2, we can see gross constriction in both the eyes with some tubular vision being maintained in the right eye. Probably that is the reason the patient has good vision, that is the tunnel vision, and the left eye does not have good vision. Coming to the next follow-up, when he came in 2019, where he was suggested to undergo genetic testing. This is the Optos image in 2019, which is similar to the previous picture, only showing mild to subtle progression in both the eyes. This is the autofluorescence image in 2019, where we can see classic hypoautofluorescence areas along the vessels and lined by an area of hyperautofluorescence. The other eye also shows hypoautofluorescence areas along the vessels and the pigment clumps, but this is more marked than the right eye.
Can you just halt for a moment? Can you go back to the field chart? I want somebody, the front row. Would this be, what kind of a field program is this? What program is this? Is it written there on top of it? You can read it. 30-2. Is this the program you would prefer in this kind of a patient? If not, what other program would you choose?
10-2 for the macula.
10-2 for the macula. Okay. Anything else? What is the aim of your field chart in this patient? Is it to evaluate the macular area or peripheral area?
Peripheral area.
So what would you choose? Next person, what is the ideal field chart for this patient?
120.
120. 120. All right. So if you have only Humphrey machine with you, 120 screening is what you do. If you have Goldman perimetry, these are ideal cases for Goldman perimetry. You would like to chart the entire periphery. If you see now if you see this chart, you think it doesn't have any vision except tubular vision. But go to the fundus photograph next. Now, if you see this autofluorescence, the periphery beyond the area of autofluorescent area, there is still a lot of functional retina. Okay, so he has significant peripheral vision, which is undocumented. So just going by 30-2, you will be totally misled into the amount of field he has and the severity of the disease. Okay. So, what is the difference between 120 screening and 30-2 in terms of sensitivity being tested? Why?
Because the number of sensitivity points that we are testing will be less.
What do you mean by number of sensitivity tests? You're testing more spots than 30-2.
But the distance between the two spots as in 120-2 compared to 30.
Strategy. This is threshold strategy. 30-2 is a threshold strategy. Means each spot you try to threshold by going up and down to see what is the optimum decibel level at which he or she sees the spot. While 120 screening is not a threshold strategy, it's a screening strategy. So how do you do a screening strategy in general? Do you randomly pick up one decibel level and throw it all over the place and ask them to say yes or no? What is the screening strategy for a field chart? Very good. So you test 4 spots, one in each quadrant, and then average it and use that as the level at which you test all other spots. Then it becomes yes or no. But basically, you have some parameter for a given patient to choose from. That is screening strategy. Okay. So screening strategy is useful because quickly you can finish off the entire field. Just imagine if you have to do threshold for 120 degrees, because patient becomes very, very tired. You won't get any useful data at all out of that. That's why you use screening for wider field charting. All right. Okay. Go ahead.
Coming to the recent most visit, which was on 5th of October 2022, when he was 23 years of age, we can see that the right eye vision was 6/9 maintained, and the left eye also was maintained at counting fingers 50 centimeter. The color vision was normal, anterior segment normal, except for early cataractus changes in the left eye. And this was the fundus picture as compared to the 2019 picture, where we can see very minimal to subtle progression probably in these areas as compared to the last visit. The autofluorescence also showed a similar picture with a line of hyperautofluorescence along the hypoautofluorescence. So this is the full field 120 points, which was done recently, which showed that the patient was seeing only 33 points in the right eye and only 4 in the left eye. So this is to summarize all the fundus photographs that we have of the patient from 5 years of age to 23 years of age, and the gradual progression of the disease that we are looking at. With this in mind, the clinical differentials at this point of time would be whether it is a pigmented paravenous chorioretinal atrophy, whether it is a rubella pigmentary retinopathy, whether it is a viral optic neuroretinitis, which was superadded on a dystrophy which got presented later on in his life, or is this an RP variant? We'll be moving ahead with the genetic case discussion by Dr. Sripriya ma'am. Over to you, ma'am.
So, coming to the etiology of PPCRA, considering this index case is a query PPCRA, so there are many inflammatory condition that is associated with PPCRA, like tuberculous spondylitis, congenital syphilis, rubella retinopathy, and cystoid macular edema. And there is also a genetic preponderance reported in cases where an autosomal dominant pattern of inheritance is observed, and predominantly these cases showed mutation in the gene called a CRB1 gene. And also there are sporadic cases reported, and there are no mutations also identified, and it has been postulated that it can be an X-linked inheritance. That is the basic difference between, in an autosomal dominant, any one of the parents will be having the disease, and with each generation exhibiting the risk with 50%, or it can be sporadic where you don't find the disease in the parents and suddenly in one generation the disease appears and there are no other affected members in the family. Or it can be an X-linked where you see the male preponderance, only the male members will be affected, and the disease is inherited from the maternal side, like the maternal history in the maternal uncle or maternal sister's sons, like that. And there is also there are also reports where they have shown that in cases with chronic granulomatous edema, and also there is a genetic preponderance, they have observed this PPCRA, and mutation in genes coding for the mitochondrial pathway, and there are 6 genes for it, and they have shown that mutation in any one of these genes are associated with this condition, and where they emphasize that along with an ocular, a systemic evaluation for the associated inflammatory condition should also be examined. So coming to the role of CRB1, so this CRB1 gene is an gene which has been seen to be mutated in various types of retinal degeneration like LCA or EORC, that is early onset rod cone dystrophy, or adult onset RP also. And this is the report that, which summarizes the ocular findings seen in along with, seen in patients with the mutation in the CRBM gene. So coming to this index case, so this case was tested for, since it was, doubted as a query RP variant. So the patient has underwent an NGS-based screening, that is the next generation sequencing based screening, where all the genes that are so far reported in IRDs were covered. It is a panel-based testing. And apparently, the patient did not have mutation in the CRB1 gene. But instead of, in addition, there are mutations in 2 other genes that has been identified. So if you see the table here, which lists the gene and then the location of the mutation where it is present, and the details of the variant, the zygosity, the disease that is already associated with this gene, and the inheritance pattern based on the literature is given here, and the classification of this variant. So now if you try to correlate this finding with the index case family history, so this result is not conclusive, because here we observe that there is an heterozygous variant that is observed for both the genes. So considering the disease as a sporadic event based on the family history that is given, where there is no consanguineous marriage and there is no other family members affected, the inheritance pattern is more favorable for either an autosomal recessive or a sporadic event. So in an autosomal recessive inheritance, we find the mutation in an homozygous status where both the parental allele will carry the mutation. Therefore, we expect that there will be an homozygosity, that is homozygous mutation. And then, but here we observe heterozygous mutation. And in not only this, there is another gene which is involved. Again, that is also in heterozygous. Now, considering this heterozygosity, any one can be the causator, considering it as a sporadic event. But if you see the disease that has already been associated is more with retinitis pigmentosa or retinal cone dystrophy. But if you take the classification, it is reported as an uncertain significance. That is, if you take any genetic testing report, we'll be either identifying the mutation that is already seen in the literature in patients with a similar condition, or it can be a novel variant. So there are certain guidelines based on which these variants are classified. And these novel variants for which we do not know any information in the literature, they are classified as an uncertain significance. So considering all these details, the genetic diagnosis is not conclusive. Like that is, we cannot take this result straightly for the further details. And also it lacks the clinical correlation, like based on whatever we have seen. So now what we can do next is, so if you take the guidelines that is generally followed for reporting any genetic variant, so the variants are classified either as a pathogenic variant, that is the variant is already reported and seen in a similar condition in other population, or it can be likely pathogenic, that is it is consistent with the genetic, that is it is seen in the gene that is already been reported in the similar condition. But if you take the third classification, that is variant of uncertain significance. So as I told you before, the mutation is first time seen, and it is also here, as in this case, it is in a novel gene. So for us to further get a clue from this, we need additional tests like parental testing. So if you want to rule out the inheritance pattern, first we should see whether it is a sporadic or and autosomal recessive at the level of molecular testing, I mean molecular level, whether it is answering the inheritance pattern. So you can ask, like, since it is an heterozygous, how it can be an autosomal recessive, but there are conditions where it is called as a digenic inheritance pattern, where you observe mutation in two different genes in an heterozygous state, I mean, resulting in an autosomal recessive inheritance pattern. So therefore, only after testing the parent status, we will be able to classify the variant, whether whether it is of type PS2 or PM6. I will go to the next slide and then you will understand what it is, to show that whether it is.
Just one. So the point which you said, that if there are different mutations, each is heterozygous, how would you call that as homozygous if it is in the same gene?
No, sir, homozygous at the molecular level. So if you
Maybe we could use a mic.
If you take an autosomal recessive disorder, at the molecular level, there will be zero functional protein. That is, both the genes are defective. Therefore, you don't have a functional protein to do its work.
Yep.
But in the case of a digenic inheritance, where 50% of one gene is defective and 50% of another gene is defective, bringing the disease nature. So that's how they classify the digenic inheritance. So as I was mentioning here, so it can be either PS2 or PM6. So this variant, where we call it as a de novo, that is, the variant is not observed in the parents and it is a sudden mutation that has happened in utero when the child was growing. Or if you have any functional evaluation, that is, if you have the mRNA, or if the gene is expressed in, depending on the expression and the function of the protein, if you can assess at the functional level and show that yes, this variant is really affecting the protein, then we can come to a conclusion. Or if you have any biochemical testing which to prove that the effect of the variant that you have observed is really affecting the function or the structure, then we can go ahead with the next level of level towards the conclusion towards the genetic diagnosis.
So again, with respect to this patient, if you test the parents and you find one of those two genes is heterozygous in the parents, would its significance level increase?
And we should also have a clinical evaluation of the parent also, sir. So
Clinically,
because
they both are normal, of course.
then we should also look at the normal database. That is where it can be a polymorphism also that is seen in the general population. And then if it is, there is a more chance that it can be an polymorphism rather than a disease-causing variant, if you observe that in the.
But since it's been associated with relative disorders like cone rod dystrophy, which you mentioned, does its significance become more than simple polymorphism?
But clinically, you should have the evidence, no, sir. If you are
Clinically,
clinically sure that it is a cone rod dystrophy, and then you have the genetic evidence, then put together, we can come to a conclusion.
All right. Okay. Thank you.
So moving to the next slide.
May I ask a question? May I ask a question?
If you take just out of this focus, so if you take for any, sorry. So if you take for any genetic testing with an IRD suspected individual, based on the clinical evaluation, they are referred after a detailed clinical evaluation to the geneticist or for an counseling, where we do a pre-test counseling and then recommend the available genetic testing for them. And then based on the patient's consent, we proceed with that. And then we can get, as I told you, any one of these variants. So if it is a pathogenic variant that is identified, then there is no issue, like you can correlate with the clinical, and then it can be further applied to the rest of the family members for the either carrier testing or predictive testing. If it is a variant of uncertain significance, we have to consider testing especially the family members and other affected family members if they are available. And if it segregates, the mutation is seen only in the affected and not in the unaffected members, and then we can say that it is more close towards the genetic diagnosis. If not, the clinical management is based on the current guidelines. So this is how this is how it is recommended for any genetic variant. So then now coming to, so therefore, after getting the result, now we know that it is an VUS. And so the recommendation is it can be when we have to go ahead with the screening of the parents, and then other affected family members if it is there. So then we will be either, coming to a conclusion, if it is a variant of PS2 type, where it, as I told you, it is a de novo variant, and you don't see that in the parents. So then, and also, so this is taken from an article that was applying the criteria by ACMG for a cardiac disease. So therefore, you can find that as a cardiac evolution. Sorry for that. But this description of the variant is common for any genetic disease. So the parents should demonstrate a normal evaluation. Then you say that, yes, it can be a disease-causing variant, but it is a de novo variant, not seen in the unaffected parents. And also, if any other unaffected family members are there, they should also not present with this variation. Or it can be a PS3, where the type PS3, where you have a well-established functional correlation. As I told you, you have to correlate with the cell culture or an mRNA-based studies. Or it can be a PM6 type variant. So in this case, we have the parents available. Suppose if you do not have the parental or the both paternal or the maternal sample available, you assume that it is a de novo, and it can benefit from further clinical evaluation and screening of the other family members. Or if you have multiple affected family members and then you co-segregate that within the deceased person, then you classify it as a PP1. Accordingly, the benefit of further clinical evaluation and counseling and other family members is got for the pedigree. And or if it is going to correlate with the patient's phenotype. As the sir said, if you are going to further evaluate and then show that it is really RCD, and then you find that the parents are normal, or it can be either a de novo or digenic, then based upon the phenotype correlation, we can say that, yes, this is genetic and this is the genetic diagnosis in the family. So thus, with this information, we can further proceed with either diagnostic testing, or in the other family members, a carrier testing or a predictive testing in the next generation, if we are going to narrow down the genetic diagnosis here. So both the clinical correlation and screening of the other family members is also important here. So, thank you.
The role of whole genome scanning.
So that can also be done, but because I didn't mention here, so they have done the targeted panel-based testing, where only the known genes for IRDs are screened. Now the next level can be, there is something called the clinical exome testing, where all the genes that are so far implicated in the other diseases, like not only ocular, other clinically important systemic diseases are also covered. So we can either ask them for a reanalysis for the rest of the panel once again, or they can go for an whole exome sequencing, where all the coding regions. So instead of whole genome, whole exome can be the first preference. Then ruling out that, then we can go for an whole genome sequencing.
Is it possible?
Yes, sir, with the same outsourcing company, they do it. So only the cost differs, that's it. Thank you, sir.
Before Dr. Sripriya leaves, any questions for Dr. Sripriya? Yep.
Genome sequencing or targeted for a first time?
That's the same question I asked her. That's exactly the same question I asked.
So we can go based on panel-based testing if we are very sure with the diagnosis. And we give this option to the patients because the cost differs. So therefore, ideally, if we are very sure about the clinical diagnosis, panel-based testing is preferred, because if you do a clinical exome sequencing, and if the patient is asymptomatic for any other systemic diseases, so the results, if it is going to pick up any other variation, then psychologically the patients, sometimes they might not be in a position to accept it. So therefore, when we do the pre-test counseling, we explain them all these things and then give the option to the patient. And if they say that, yes, we want to go ahead with the clinical exome sequencing, knowing that they will get other results also, we get the consent from them and then go ahead with it.
Thank you.
What's the turnaround time for this?
Turnaround time is around 1.5 months, sir. Sometimes it takes even 1.5 to 2 months. Mostly we get it within 1.5 months. And then what we do is we have their genetic inheritance and other pedigree charted done in our lab. So we don't disclose the patient details to the company. So therefore we do another report where we give the details of the MRD number and then the family details, and then attach with this and then send it to the patient. That's how it is done.
But we can also do targeted gene testing, right? Suppose today
That
say
is
I say
preferred, sir, actually.
like for
target.
example, I say this is definitely retinoschisis.
Then
So I
targeted.
want to do a targeted gene testing, and how much time does it take for a targeted gene testing?
See,
Is the same?
if you go by NGS based testing, the turnaround time is the same. But in this case of suppose you have a juvenile retinoschisis where we know that it is for sure juvenile retinoschisis, we can screen only for the RS1 gene. So which becomes a candidate gene based approach, and that is done in with the direct sequencing, which can be done in house itself. Sir.
In the NGS screening, do you also do mutational screening? I mean,
so
the type of mutation and stuff like that. To each level do we go?
I didn't get you.
I mean, mutation in the sense we have all this various null mutation, frame shaped, in frames and stuff
the
like that.
report mentions also this. When you see the report that I have shown there, the research section, it mentions in one column the exon number, what is the cDNA change and what is the protein change. And inside the report, they also discuss about the reported literature, like from the OMIM, what is the evidence. Based on the literature, they give that also. So here,
May I ask a question, please?
the exon is located, and so this is in the cDNA position 149. The nucleotide A is changed to T, which is resulting in the amino acid change at the protein level from ASN to isoleucine.
Okay.
So this is how they give. But when you go deeper into the rest of the section, the discussion part, they also interpret these results by quoting different literature.
Thank you.
But the thing is, only if it is a pathogenic, then it is a direct. If it is VUS, then we have to do all the other screening, that which can be done in house itself with the direct sequencing. They need not go for an NGS for that.
Yeah. Thank you, ma'am.
Thank you, sir.
Ma'am, Dr. MPB, ma'am.
Yeah. Nice and interesting case, Ramya. I noticed actually you've shown only the posterior pole image of the case at presentation.
Ma'am, we
But
cannot hear you.
I noticed there were only posterior pole images. Yeah, actually I went through the file and I saw the peripheral fundus images of the child at presentation. Though the quality is not very good, even then there is the perivenous pigmentary changes which are very mild. Now my question probably to Sripriya is, with any inflammation and carrying these variants of uncertain significance, will any inflammation precipitate a picture that appears like a hereditary dystrophy?
But these genes are not involved in any inflammatory condition, ma'am. Whatever they have reported.
No. The inflammation is not connected, but the presence of a gene in the patient that is of uncertain significance,
But
will
we
that
have to, as I said,
precipitate more changes in the retina if the patient has inflammation, is my question.
ma'am, since it is a VUS, first we have to do the co-segregation in the family members. If that is going to be seen in unaffected members, then that rules out the variant to be the causative one. So only after that we can further correlate the clinical picture, ma'am.
Sure. Thank you.
Thank you.
If I understand your question, Dr. Mona,
Yes, sir.
does that mean that the presence of this genetic defect can predispose them to a more severe manifestation with an infectious etiology? Is that
Yeah, that's what I was trying to ask.
okay? Because according to the literature, at least, they don't combine the two. They just say that the etiology could be inflammatory. These are all hypothetical, obviously, nothing proven. Any infection or inflammation, why should it choose to be along the vessels? Nobody knows the answer. Or is it genetic? So I don't think they were trying to mix the two, but I think that's an important question. Yeah.
Yeah, and it's a little asymmetric, so that's why. Though PPCRA is known to be asymmetric, that was also something that made me wonder.
Actually, I was thinking in a different format, in the sense, I was thinking of both diseases occurring in the same patient, but not connected to each other, but independent of each other. But the end result of damage to the retina is common.
Yeah.
And the initial damage was severe in the left eye, but was milder in the right eye, which recovered actually from finger counting, has come up to 6.6. So the improvement is something which we wouldn't expect if it is a purely degenerative pathology, or if the degenerative pathology is initiated by an inflammatory pathology, even then I wouldn't expect an improvement to happen. The fact that it improved in one eye tells us probably that we're dealing with an inflammatory disorder at 5 years of age, superadded on a predisposition to a retinal disorder, genetic disorder, which showed its full impact by the time he became 23 years of age.
Yeah,
Before
that's
we
what I
continue,
meant actually.
we have to do the co-segregation. If it is a polymorphism, then it is not going to precipitate in any pathological conditions.
Thank you, ma'am, for your valuable inputs. I now call upon Dr. Raja sir for ERG discussion. Over to you, sir.
Has the ERG worsened in the right eye, the manifestation?
There's only one ERG available.
Only one ERG was there. Because
Patient was advised multiple times, but patient didn't undergo the investigation.
because as sir said, the first insult itself in the left eye was more than the right eye. It has continued to just show the changes that are degenerative. So you have a lot of pigmentation happening in all those places. But the right eye seems to have just that area which is involved, and that has continued to have more pigmentation, preserving the central thing. It's as though the degenerative area did not manifest itself so well in the early stages, but later on we start seeing the degeneration as a patient is growing. But I don't know whether there's actually a dystrophy in play here. The ERG could even be a secondary manifestation to whatever retinal RP changes that we're seeing. That is my query.
I think two important evidences in the jigsaw puzzle are missing. One is fields at periodic intervals, which were not done.
Very big.
And ERG we have only at one time, which is probably at a more advanced stage. We have no idea. One thing you can do also is compare the first photograph, that is the first wide angle photograph, with the last wide angle photograph, and see whether surface area of the RPE damage, is it different? I know the pigmentation is different, RPE atrophy is different, but the amount of sum total of the RPE damage evident in the first picture, although it is yellowish versus normal pigmentation, but is it the same? In which sense it tells us that over a period of maybe 15 years at least, it has not extended transversely, but only in terms of the intensity of presentation of a atrophic patch with pigmentation. Having said that, the autofluorescence did show a rim of hyperautofluorescence, and that we know tells you that a disease is progressive. If it's a dead disease which is non-progressive, usually don't get a rim of hyperautofluorescence. That is indicative of still a progressive problem.
Show the picture again.
I remember that the RP atrophy, at least in the macular area, has progressed. Yeah. So you can see the first wide angle photo. Yeah. Yeah, so isn't it? Yeah, from the third photo and the last photo, you can see the area of the normal looking retina at the macula has become shrunken. It is shrunken. And in the lower area.
But you can't compare the two images, ma'am. One is an optos and the other is a wide field multi thing. Seems to be the same almost. If
No,
that's what
probably
if you can do.
You can enlarge. No, can you just show single images?
You
look at the vessels and all that.
So that is what sir was trying to say, ma'am. If you can actually measure that distance between the exact atrophy that you see, and then you compare with the wide field, and you have a scaling on the optos, you can tell the area. You have to look at the scaling and then you can do it.
Yeah, it shows. No, it has increased. See the.
Ma'am, it is still, ma'am, it is 2 disc diameters in diameter. I don't see that. Left eye is where the PSC catheter is developed.
Left
so you
eye,
can't
no.
see the macula.
Right eye, you look. Go
Still,
back to
ma'am,
the
the same,
previous one, right eye.
It does show the same thing, ma'am. And this problem is there's a stretch. This is the problem with comparing wide fields, ma'am. There's a stretch in the images.
If you concentrate not on the yellow part, but on the normally pigmented patch,
yes, sir.
It's almost identical. You see that? The brown pigmented patches? Almost, I mean, there will be always some difference. Why do you think we are so worried about this? Why do you think we are so worried about whether it is changed its surface area or not?
Know whether it's going to progress further.
Yes, it's something, a very important information you can share with the patient's parents. That is probably it has not progressed much over a period of 15 years, except that the area involved has become varied morphology, but surface area has probably not increased. That's a tremendous good news for them, right?
Before going into the discussion of ERG, we have 4 differentials here. First one, pigmented paravenous chorioretinal atrophy. Second, rubella pigmentary retinopathy. Third one, viral optic neuroretinitis, superadenoma dystrophy, and the fourth being RP variant. So last time also when I discussed on ERG, I told you that before sending the patient for an ERG, we should have an idea on why we are sending it and what we are expecting from it. So before sending, we are having these 4 differentials. So now we'll go into the ERG and then differentiate between these 4. So coming to the ERG, if you see the single flash response or a scotopic 0.01, the B wave is not seen. It's almost flat in the right eye, and in the left eye also the B wave is completely flat. Coming to the scotopic 3.0 response, you still see a B wave, but it is grossly reduced in amplitude. Here you still see a B wave, but it is grossly reduced in amplitude. Unfortunately, I don't have a normative data or normal for comparison for this ERG. And the scotopic 10.0 again shows grossly reduced B waves, and the A waves are also reduced more on the left side. So similarly, the scotopic, these are oscillatory potentials, and the photopic response also, if we see, there is no obvious peak that is noted, more pronounced on the left side. The scotopic flicker, right eye, we still see some amount of waveforms. Left eye, that is also not seen. Now comparing right eye with left eye is more affected. The amplitudes are grossly reduced in the left eye, and right eye also it is reduced, but it is relatively less reduced. So coming here, we have both the scotopic affected and the photopic affected. So both the cone system and rod systems are affected. One. Second, for a change in a full field ERG to occur, at least 20% of the retina should be affected. So with this, can we differentiate between the 4 differentials that we had before? So coming back to our differentials. So what is pigmented paravenous chorioretinal atrophy? There are atrophic patches adjacent to the vessels. So these atrophic patches are not going to elicit a electrical response. So obviously pigmented paravenous chorioretinal atrophy is going to reduce amplitudes both in the scotopic and photopic responses, and how much it reduces is based on the amount of area affected. The more area that is affected, the more reduced the amplitudes are going to be, the better. The less area that is affected, the amplitudes are going to be higher. So does this diagnosis fit with our ERG? Yes, it does. Second, coming to rubella retinopathy. In rubella retinopathy, there will be plenty of pigmentation, salt and pepper appearance, but is our ERG going to be affected? No. Our ERG is going to be completely normal because the retinal layers or the function is not affected. So does this fit our ERG? Does this diagnosis fit our ERG response? This does not fit. Third, coming to viral optic neuritis superadenoma dystrophy. So patient had a retinitis or inflammation, which can eventually lead to scarring, which is seen as the CRA. Again, CRA can reduce the amplitudes. CRA will not induce a electrical response. So does this fit into our diagnosis? It can. It still can. Is this an RP variant? So usually RP in adults, most typical cases will have flat ERG or non-recordable responses. But in early phases in children, RP can still have waveforms. It can still have reduced responses and eventually become completely flat. So this ERG was done in a child, it was not an adult. So this ERG was done in 2017 and the child was around 16 years, I suppose. So this could still fit into a RP variant, wherein eventually it can become completely flat and it will help in our diagnosis. So having only these differentials and having only the ERG into account, this does not fit into our differential. Although this alone is not required for a diagnosis, it should be clinically correlated also. So how else to go about is serial ERGs on subsequent visits, compare it with the previous ERG, whether the amplitudes are further reducing or is it stagnant. So if it is stagnant, similar to before, what does it mean? If the ERG amplitudes are maintaining, it could still be PPCRA. Or it could be old inflammation-induced chorioretinal atrophy, which has settled, the inflammation has settled, so the disease is not progressing, so the ERG is still maintaining. Okay. If it is RP, it is going to gradually become flat. And if it is a cone rod dystrophy, similar to our genetic findings, ERG is going to further drop. So having an ERG alone is not going to help us in a spot-on diagnosis. However, clinical findings and its correlation, and in this case particularly, subsequent ERGs would have helped. Obviously, the patient was advised ERGs on subsequent visits, on the previous visit also, but the patient did not undergo.
Can I ask one question?
Yes.
If we remove in the third option of diagnosis, the second half, it was just a post-viral optic neuroretinitis, what would be the ERG expected?
It can be reduced, sir, similar to what we got, sir. Because this does not prove that we have a dystrophy, sir. The ERG findings and the genetic report of an uncertain significance does not prove that the patient has a dystrophy.
No, if there's mainly optic neuroretinitis, in most cases of so-called neuroretinitis caused by various organisms, the inflammation is restricted to the posterior retina, not to the entire periphery.
Yes, sir.
But let's assume that there was no pigmentary degeneration as we see in this fundus picture. I'm talking about not this case, but a different case.
Yes.
If you have optic neuroretinitis and sequelae, would ERG be affected to this degree? I thought probably the ERG will be much better preserved. VEP can be affected, yes.
It would have not been this much reduced, sir, but based on the amount of inflammation that was present, the ERG amplitudes can vary, but not this reduced.
Not to this extent.
Not
all
this
right,
extent.
okay.
But neuroretinitis, generally, we don't see much things on the ERG. No, you're seeing the photoreceptor response is poor. It looks like, I don't know, sir, if I can just throw out a thought, there is something, there's another entity which people have used in past, an azure-like entity post any infection in the eye.
Azure.
Yes, sir. So this kind of picture can be there, and because it improved, because of your steroids, and that's where you stopped the disease. Azure has got no role. Steroids have got a plus-minus role in Azure. But at that point of time,
Azure does not have vascular sclerosis. It does not have optic disc atrophy.
correct, sir.
Azure is purely outer retinal layer.
Absolutely, sir. So the outer, there is a etiology which has affected two parts of the vision system. One is probably an autoimmune retinopathy which has occurred, and one is the nerve. Both are involved in the second. So there can be a second autoimmune response to whatever viral etiology was there. There may not have been an actual viral etiology because we don't know about the prodromal fever and stuff
We
like
don't
that.
know, yeah.
But this could be an autoimmune in some form, because neuroretinitis also, sir, is a disease of exclusion. You have to find out, and most likely it is like you do a lot of multiple tests.
And then in most cases of Azure will not improve. That's another important thing.
That is true, sir.
Somebody improving from finger counting to 6/6 will never happen with Azure.
That's what I'm saying, sir. That was probably because of the neuroretinitis part
Exactly.
was recovered. That
Basic
recovered.
diagnosis initially was still acceptable as a neuroretinitis. So my question was, the retinal damage, there is also retinitis and neuroretinitis.
Yes, sir.
But it's a very small patch of retina which is affected around usually the peripapillary area. You have more of hard X-ray, the so-called macular star appearance, and it is seen with various organisms, including toxo, syphilis, and various other organisms, but it doesn't produce extensive retinal damage enough to cause ERG to be grossly reduced, and neural can improve.
Yes, sir.
with
Definitely can
time.
improve.
And
What I'm trying to say is an overadded, a secondary autoimmune retinopathy has occurred at that age, which has recovered and has not progressed till now today. It's very strange. It's just not progressed. It just remains the same. And
I don't know. Basically, I think that is the one option you're thinking about. Is another possibility, another possible diagnosis you're trying to put in.
yes, sir. It's a paraphenomenon, sir. It is not a real. It's like it's not a true phenomenon, but it's a paraphenomena. But they call it here. They don't call it paraneoplastic order, but it's a another phenomena, epiphenomena that happens when there is a inflammation in the eye. Because we see this RP changes, they are very extensive, and it's only popping up in that area where there's already damage. It'll be interesting to see whether we can follow up this patient and see any changes in the central. It's just around maybe less than 1 degree now, so left cones in the center. And that is where we have to, he has to be actually probably seen more closely. I don't know about ERG, but definitely we need to keep seeing his OCT much better. And his visual field, in some ways, we should try to find. I also miss the Goldman. The Goldman was probably the best way to pick up the areas of seeing retina.
Sir, in rubella retinopathy, I agree it will not be this pattern actually.
Which one?
Rubella retinopathy.
Mhm.
But rubella retinopathy is after all a retinopathy. It's a pigmented retinopathy. Why should the ERG be normal?
I don't know, but that's what is described.
Yes, sir, that is described.
That it obviously means that despite the pigmented disturbance, and it's not like pigment migration into the retina and bone corpuscles are not typically what you see. You see a vague kind of a salt and pepper. Salt and pepper is nothing but patches of RP atrophy followed by, and also some amount of hypertrophy. But the amount of damage is probably not extensive, and there's no retinal architectural damage that's taking place, which is the reason why you have maintained visual acuity and maintained ERG. By the fact that ERG is maintained, we understand the retinal architecture is not totally damaged. So that is basically what is well described in the literature. So that's the important way of differentiating between the two.
Next time we should get the ERG when he comes back, get the ERG and see what his ERG has changed. Most likely it will probably almost resemble this. You may have a cone response, but you'll have a very low amplitudes, and the implicit times probably would probably.
MPB, ma'am.
Yeah, I think look carefully at each photograph, and we will see that it's not really the area that is involved. It's more of a change in pigment. And possibly the macular changes could be due to the neuroretinitis, because we know neuroretinitis causes hard exudates at the macular edema also. So maybe some of the macular changes could be due to that, because PPCRA is traditionally not known to involve the macula. And if it remains stationary, then yes, it's probably not RP. It could be just PPCRA, which is also known to be stationary.
Thank you.
Yeah, okay, good, Dr. Rajat. Thank you. I think
Thank you,
Dr.
sir.
Ramya will put the whole story into one package. Go ahead.
Thank you, sir. So with the genetic testing, this was the report, and we saw that there was a mutation in KCNV2. Ma'am? MPB, ma'am?
No, nothing.
So there was mutation in KCNV2 and also in MAC. So little about the phenotype in both these conditions. So phenotype of KCNV2 retinopathy. KCNV2 basically affects the voltage-gated potassium channels, which is responsible to maintain the resting membrane potential of the photoreceptor. So this causes an autosomal recessive cone rod dystrophy with a pathognomic ERG finding, which is cone dystrophy with a supernormal rod response. In this condition, the patient usually presents in the first and second decades of life with gross visual disturbance, less visual acuity, and some of them also complain of nyctalopia, some with also photophobia, which is a rare thing to happen in an early stage of cone rod dystrophy. In the fundus examination, what is striking is there is a normal retinal periphery with macular abnormalities, which can range from mild attenuation of FR, that is foveal reflex, to RP atrophy in the macula. Fundus autofluorescence corresponds to the fundus picture, which can be like bullseye changes, increased foveal autofluorescence, reduced central signal in keeping with the atrophy. OCT also shows mild discontinuation, reflectivity of the ellipsoid zone, and central hyporeflective zone. So in here we can see the described changes. It can vary from a mild EZ loss to a hyporeflective zone under the fovea to gross EZ loss and outer retinal atrophy, which is corresponding to the fundus autofluorescence images. The right hand side shows the pathognomic ERG finding, where we can see a diminished response in the 0.002, whereas a delayed but a supernormal responses in the other dark adapted potentials and a reduced response in the light adapted potentials. Coming to the autosomal recessive RP, due to the MAC gene or the male germ cell associated kinase gene, we all know that more than 300 genes are implicated in RP and over 80 genes are associated with RP. But what is special about this MAC gene is it causes autosomal recessive RP, which is known for preservation of the foveal vision. In our patient also, we could see in the right eye there was preservation of the foveal vision, even in advanced stages of retinal degeneration, despite similar rates of peripheral visual loss. In a paper by Liu YJ et al., who studied about the high resolution images using OCTA and adaptive optics SLO, showed that there is reduced superficial and deep capillary plexus around the fovea and increased cone spacing despite well-preserved visual acuity in eyes with advanced stages of this disease. However, the foveal avascular zone area and vascular densities at the fovea showed no significant difference from the normal patients. So they hypothesized that this could be the cause of maintenance of a foveal vision in such cases of RP. Coming to the phenotype that we have at our hand with this patient, which mostly correlates with the PPCRA, pigmented paravenous chorioretinal atrophy, which is normally characterized by RP choriocapillaris atrophy and pigmentation along the retinal veins. It is bilateral and symmetric but appears to have variable expressivity. Mostly these patients are asymptomatic and exhibit non-progressive or a very slow or subtle progression of the disease. The family and medical histories are non-contributory. Gender predilection is not distinct. However, there are papers saying males are more affected. Etiology is something that is very intriguing in this. As Madam discussed, we have most sporadic cases. There is a paper published in the IOVS which showed a family of inheritance of autosomal dominant PPCRA, but all of them had uncertain significance in them. So this was correlated with the CRB1 gene. There's also another paper showing association of this with HK1 gene. But the most intriguing part is this, that is inflammation or infection. Most of the PPCRAs are noted to be following an episode of inflammation or infection, and they're termed to be pseudo-PPCRAs. So this is a photo essay published in the IJO, which shows the fundus images and the autofluorescence images as, and I've put the images of our patient for comparison. This is almost similar, so we can think more in terms of PPCRA. Also, the visual fields, 120 points, the ERG and the OCT shows similar findings like our patient. Coming to a cohort study, this was a cohort study with 23 people having pigmented paravenous chorioretinal atrophy, out of which we could find that there is one patient who presented similar to our patient. That was, he was noted 3 years after generalized flu-like symptoms, encephalitis and optic neuritis, which developed 3 weeks after MMR immunization at the age of 4 years. He was noted to have retinal edema at the time of presentation with optic neuritis. 3 years later, when he presented with this fundus picture, which is similar to our patient as well. Coming to an in-house publication by Dr. D.A.D. Madam, which shows concurrent retinitis pigmentosa and PPCRA in the same patient. This was a 32-year-old Indian woman who had phenotypical picture resembling typical RP in the right eye with night blindness and constricted field of vision and a non-recordable ERG. But the left eye of the same patient revealed typical PPCRA phenotype with no night blindness, normal fields, and normal ERG. However, the patient did not undergo genetic testing here. This is the fundus image of the patient. And what we can see is the RP and PPCRA phenotypes can be a part of the same spectrum of the genetic disorder. However, it is rare for them to coexist in the same patient.
So this was one patient, very peculiar. What was peculiar that one night she had RP like picture, including extinguished ERG in the right eye, poor vision in. So she complained of night blindness only in the right eye. Very specifically, she said only in the right eye she has night blindness, and then she had this poor vision, extinguished ERG, and this kind of fundus picture in the right eye, which looked like RP, and the left eye had good vision, no night blindness, normal ERG, and only this PPCRA like picture in the left eye. So although we don't have the genetic study for this, it would have been good to have. But I looked at the literature and they have reported some one or two situations like this where not in the same patient, but the mother had a PPCRA like picture and her two children had retinitis pigmentosa. And another report also where I think among the twins, there was one twin had PPRC and other had some RP.
Monozygotic, ma'am. They were monozygotic twins.
Homozygotic twins,
Yes.
correct. So I remember that. So that is the two case reports were there at that time, and then this. So they said that probably it is related to this CRP1 gene, and it could be an overlap with retinitis pigmentosa. Also, although there is always a possibility that this could be inflammatory, but again, having a very asymmetric picture like this in an inflammation, also to the extent that even night blindness and ERG is extinguished only in one eye, I thought was very peculiar and could be some genetic, basis for this. Did you find any further references to such type of cases?
No, ma'am. Those two case reports and this cohort also most of the patients had similar. One patient had syphilis and TB like picture inflammation. The rest of them did not have any inflammation, and then only the PPCRA part, like they had progression. That's all.
So we had all the investigations for this patient regarding the infection. So she didn't have any known infection as such, but we didn't have any genetic study for this.
Thank you, ma'am. Coming to rubella retinopathy, which was considered as one of the differentials, what we need to know is rubella retinopathy is a part of congenital rubella syndrome. That is, the mother gets infected with rubella virus in the first trimester, within the first 10 weeks of conception. The child usually presents with deafness, eye problems, and also heart diseases. It could be patent ductus arteriosus or pulmonary stenosis. But in the eye, it could be unilateral or bilateral pigmentary retinopathy described as salt and pepper fundus, ranging from a finely stippled to gross pigmentary changes, cataract and glaucoma, can be either stationary or progressive. What we have already discussed is the ERG is not affected or is just mildly affected, and serology should show 4 times increase in the IgG or the IgM. This is the classical picture of rubella retinopathy showing stippled hyperpigmentation in the fundus corresponding to the hyper autofluorescence. So at the end, what do we think it is? Some inputs from after this discussion, what would be the most probable thing that this could be? Any of the fellows, please.
I wanted to clarify one more thing. KCNV2 doesn't always give you that picture.
Yes, sir.
It's only 10% of patients with KCNV2 gene will have that kind of ERG. Most of them, they will have a ERG similar to RP. When we pick it up, then we know that it is KCNV2. It's the other way around. When you see a supernormal response, then you
Yes.
see, this must be KCNV2. Nothing else resembles that.
Yes.
But if you have a KCNV2 and you can correlate with that, you can have an RP-like picture also. I mean, ERG.
Okay.
I think if all of you throughout the presentation, you to be anything specific. If you don't, it's not going to allow you to go home. Why don't you ask?
You quoted one reference now that
Yes.
MAC associated RP.
Yes, ma'am.
So does this patient fit into this description?
Can, ma'am. Because this paper actually, they did only for 5 patients and one sibling of that patient in 5 families who had this particular gene, MAC. They confirmed the MAC mutation and then saw the high resolution imaging. So the sample size is just 5 plus one sibling.
Also, problem with all the disease is that this is a cross-sectional study.
Yes.
You need to follow up the patients to really come to diagnose that MAK was this is the pattern of disease for thing. I mean, just put a cross-section, 5 patients having the same,
Yeah.
it's like a bias.
Correct.
You're seeing patients of the same nature and then you go and dig out a gene and say this is the cause of that. We should follow up a case. I think a lot of cases have to be followed up over a long period of time. See the progression only, then you can, yeah, this probably could be that. If the progression is similar pattern in a lot of say, patients, then you can actually say that this probably was the gene which caused that.
So coming to what we think it could be either a pseudo PPCRA, as I described, it precedes with an inflammation or an infectious event, or it could be an autosomal recessive RP. So what would we do to get more information? A detailed pedigree charting would help. Evaluation of the family members and genetic testing of them would help, and a long follow-up, as Sir has told. So coming to two nice to know facts, that is PPCR and macular edema, although not much reported that it can occur like in any other dystrophies. But this paper showed that neither topical dorzolamide nor anti-VEGFs did improve anatomically or functionally. So this is something we can ponder over. Also, vitritis in pediatric genetic retinal disorders. This was a paper which showed cells, that is vitreous cells. We started our case with some vitreous cells present. So we can also think in those lines. That is, this paper showed that Bardet-Biedl syndrome, almost all cases had vitreous cells, and few genetic genotypes of LCA and retinitis pigmentosa also had cells in them. A cellular response in the vitreous would suggest that the degeneration is augmented by inflammation, as Madam was quoting, and this suggests that vitritis is associated with progression of retinopathy and perhaps with photoreceptor cell loss. Yeah, other findings as well. This, no, not in this relation, just a nice to know fact. And this, they also presented a Venn diagram, which is a good picture to have with us, just to know whether which genotype will present with cells and no cells. With this, I would like to thank all my mentors and my colleagues who have really taken efforts to help me in this presentation. Thank you one and all for patient listening. Thank you.
Then you can take a show of hands within the two diagnoses. Who thinks it is pseudo PPCRA and who thinks it is autism recessive after your discussion? If you have...
I think before that, let me ask, what is the difference between pseudo PPCRA and
PPCRA is just the pigmented paravenous CRA, sir. We rule out all the inflammation or infectious event prior to that, and if we do not get anything, then the patient is named as PPCRA. Otherwise, if the patient is having some inflammation or an infectious event, post which the PPCRA has occurred, in literature it is described as pseudo.
Always the PPCRA is a morphological description.
Yes, sir. Yes.
It's caused by inflammation, which itself is hypothetical, or by genetic basis also is hypothetical. It's difficult to call it as something else. So I would think that there is really not much difference between calling it as a pseudo PPCRA or PPCRA, because both are at the end of the day morphological diagnosis, not etiological diagnosis.
Correct.
But I definitely would not call it autosomal recessive RP because that pedigree charting did not show anything else. You should not call it autosomal recessive
The
RP.
full pedigree we have not done, so we just asked whether a patient had any similar complaints in the family.
RP simplex. With idiopathy, we have not been able to find anything.
See,
Just single.
I want to ask this question. You said that the same gene defect has been associated in the same family. You had the mother with PPCRA and somebody else with RP. And if we consider genetic origin to be similar, except the manifestation is different, one is less progressive but having some degeneration, while otherwise progressive. It's well described in RP. There can be variable progress. Could we consider it as a milder variant of RP, PPCRA itself?
So, or there is another gene which is changing the nature of the disease
We don't know.
morphology. So unless that's why I said, no, when we're looking at the gene panel, there are a lot of things which you don't know. The gene panel runs against the known mutations that we have, known genes. So we are not, and it may be not in the same segment of the gene. Suppose you may have some other in between segment of genes where there could be a modifier, gene modifier. No. Yeah, so which we don't know.
So maybe it is not within the retinal genes. As he said, we can go for an exome sequencing, look at the some other novel genes are there. Maybe we can look at by doing an whole exome sequencing.
So that is what people are doing. I mean, the UK, there's a very strong this thing. So they go with this whole genome when they talk about these modifier genes. And you don't know that this is not following a pattern. They go for the whole genome sequencing to look for these modifier genes, where if you pick it up, there's a possibility that this is probably
No,
the disease.
modifier genes will, when we call it as a modifier genus, if you have a different clinical presentation with the same mutation.
Yes, same.
But this family, there are no other additional members also. Maybe we'll find a novel gene per se. Not that maybe these two variants, if they are segregating, these can act as a modifiers and at an heterozygous level.
I still don't feel that this is a dystrophy. There's some inflammation induced atrophy, which we're seeing on a long term follow up. So
Why do you think the vision improved?
there is also, patient had some inflammation. With steroids, it reduced. In one eye, there is quite a bit asymmetry compared to the left eye and right eye. And there is also optic atrophy in the left eye, the disc is pale, and the vision did not improve in the left eye. And everything is grossly asymmetrical, not little bit of asymmetry. There is a gross asymmetry between both the eyes. And initial presentation was patient came with a sudden loss of vision, which again goes in favor of inflammation induced changes. So I still don't feel this is a dystrophy just because something popped up in the genetic test.
I agree 100% that you cannot relate the genetic testing to what we see, and that genetic testing anyway is not significant. It's not significant at all. So even if we ignore the genetic testing part, I still feel there's a dilemma in the sense it's not purely inflammatory because of the total asymmetry between the two eyes, despite the vision having the starting point and vision is almost the same at 5 years of age, while one eye improved very well, the other eye did not improve. But the fundus picture is almost similar except for the macular atrophy in the left eye. Rest of the picture is almost similar. So it's hypothetical. You can't prove or disprove anything. When people believe that PPCRE itself is caused by inflammation, although why inflammation should take that particular tree-like pattern, nobody has explained. So at the end of the day, we still are not sure about what is dystrophy and what is inflammation, but there's a link between the two, or there are two independent entities or just one entity. Anything is possible. I agree with you. Any other questions from that side?
So there was still progression in the pigmentary changes, sir. So based on an inflammatory condition, we cannot explain the pigmentary progression.
That's exactly what we were trying to say. Say that the damaged area has not changed too much. The morphology of the damaged area has changed in the form of RP atrophy and the pigmentary migration, which can occur over time. So our hypothesis, if it is all inflammatory, is that the RP damage has occurred, which are barring those strips of brown pigmentation, rest is all yellowish. And all that yellowish thing has become totally atrophic with pigmentary migration into the retina as bone corpuscles. So these are all subsequent mechanical sequelae and atrophic changes.
Hyperautofluorescence at the edges.
Yes, that's important thing. That's important thing, yeah. So if we prove that there is a progression, then obviously it becomes more dystrophic than original inflammation. All right. Any other questions?
So, and PPCRA also can have slow progression. So
Yes.
even if you document progression, it doesn't rule out PPCRA.
That's why I said the starting point is it's a morphological diagnosis. Maybe it's caused by multiple etiologies and each may have a different progress. So, but that's where we are in the understanding of PPCRE. Dr. Sripriya may not come back for every class. So if you have any questions specific for her, please ask her about the genetics. If there's none, I think we'll call it a day. Thank you very much. And it's excellent presentation, Dr. Ramya.
Thank
Very
you,
good.
ma'am.
Well researched and well presented.
Thank you, sir. Thank you, everyone. Have a great evening.